I want to share with you our experience of managing pulmonary hypertension care during the COVID-19 pandemic in the UK and the changes that we made at the Hammersmith Hospital. So to put this in context, just go back to when the pulmonary hypertension services were all set up in the UK. So back in 2001, the National Health Service designated specialist centres, and there were 6 centres, one in Glasgow in Scotland, one in Dublin in Ireland, and 4 in England. And the London centre, always to be awkward because we have a population of around 8 million in London, had 4 hospitals. One, the Royal Free, had for speciality in connective tissue disease. The Royal Brompton have a speciality in congenital heart disease. Great Ormond Street Hospital see the children in the whole of the country, and us at the Hammersmith saw pulmonary hypertension of all other causes. And the UK pulmonary hypertension service all work very closely together. We have a pulmonary endarterectomy and balloon pulmonary angioplasty service, which is run out of Papworth Hospital. We have a PH professionals forum where the nurses, pharmacists, physiotherapists, psychologists, and all other allied healthcare professionals meet up on a 6-monthly basis, as do the Physicians Committee. We have an active transplant service. We run a national audit of pulmonary hypertension, so all our data goes into that, and we produce an annual report. The NHS England specialised services keep a very close eye on us and produce policies for the drugs that we can use, which are all reimbursed by NHS England. We have an active transplant service, and really one of the most important things is we have a very active patient association, and our patients are very much at the heart of everything that we do. And at the Hammersmith Hospital, when we first started, I was working part-time, as was the consultant who first started it, Dr. Simon Gibbs. We now have 4 full-time consultants, 4 full-time nurses. We have a registrar and a junior doctor who rotate through our service. We have a large admin team to help us run everything. We have a big research team and over 1,200 patients. And to manage the fact that the pulmonary hypertension centres are all very much on the right-hand side of the country, we run outreach clinics, which we would normally regularly go to once a month. So we have clinics in Wales, in Swansea. We also go out to Bristol and Portsmouth and Hastings, and we run a joint clinic with our adult congenital heart disease colleagues in Barts Hospital in London. And as you may see, that we quite like going to outreach centres that are close to the seaside, because we like getting out of London. But I said this was all running along quite nicely, and until unfortunately the COVID pandemic hit. And so about this time last year, we were told by our Prime Minister that we needed to stay at home to protect the National Health Service and to save lives. Unfortunately, COVID in the UK has hit us very hard, and we just coming out of the last lockdown and the last big surge in cases, and we've had over 4 million confirmed cases of COVID, and actually I think there probably have been many more, and sadly over 121,000 deaths so far in the UK, and that number has sadly increased since I made this slide. And so we've had lots of lockdowns, so many patients with pulmonary hypertension have barely been out of their home for the last year, because they've all been told to shield, and that has meant that they've not been able to attend hospital for regular appointments, and we've tried to shield them as much as possible, and so that has meant that when possible, we've had telephone and video consultations, and we've tried not to bring them into hospital because this has been probably the most dangerous place for them to be. So what are the changes that we've made? So we've limited our face-to-face appointments just for new referrals that we really needed to see because we've needed to perform echocardiograms and physical assessments. We only see the patients that have needed to have 3-month assessments after changes or starts to therapy. The patients that need to come for annual reviews, or the ones that we have clinical concerns. Now, as you can see from the picture that I've put up, when we actually see them face to face, they're presented with a clinician who sits there with a face mask on, with goggles, and sometimes, especially if they're hard of hearing or trying to lip read, it's very difficult because they can't actually see the clinician's face. They come across somebody who looks as if they're dressed up as if they're going into space. And so sometimes communication is very, very difficult. When the patients would need to come in for their investigation visits, before COVID, we would bring them in for sometimes 3-4 days to undertake all their investigations. We would sit and talk to them between the investigations, explain all their results, and spend a lot of time being able to go through things, bit by bit, and being able to talk to them a lot about pulmonary hypertension. But now, because we're trying to limit the amount of time they're in hospital, they normally have their non-invasive investigations, their CT scans, their MRIs, their lung function, all done in one day case. And then they come in and have their cardiac catheter done as another day case. And so it's all very, very rushed. And then we then talk to them over the telephone or as a video consultation to explain the results, and then they start drug therapy often at home. And all the other appointments have been changed to remote consultations. So it has changed quite considerably. So what we've tried to do is improve on this to try and make the appointments as efficient, but also as satisfactory as possible. So we've changed to remote consultations, and we were starting to introduce these anyway before the lockdown. But we're running into quite a lot of red tape with the hospital and some of the companies that were bringing in the video consultations. But amazingly, as soon as COVID hit, all the red tape seemed to melt away. So our video consultations, we use an application called Attend Anywhere. And this can be undertaken using a smartphone, a tablet, or a computer. And the beauty of this is you can use multiple users at the same time. So you can have the patient and their relative, or sometimes a second person dialing in that they have requested. You can also have a consultant in one room and a nurse in another room, or a local consultant if it's one of our outreach clinics. And this helps improve communication, especially when you can see them, because when you're discussing complex or emotional subjects, it's much better to be able to do this when you can see the patient and you can see the emotions on their face. It's also ideal for troubleshooting problems such as nebulizers or intravenous lines, because you can get the patients to show us their problems. You can see their Hickman lines. You can see something that is red or sore. They can show you their swollen ankles. They can show you their pumps, and so that is much better. The only problem sometimes is when our patients live in remote areas and their internet connection is sometimes not so good. So we prefer video consultations, and many of our patients do like this. We did have concerns with some of the older patients not being able to manage the technology, but actually they've surprised us. and some of them have used their younger relatives to help them with technology, and this has actually helped them with other applications as well. And some of them have really got into doing things like internet shopping, and have been able to use the internet really quite well during lockdown. When patients prefer, that we use telephone consultations, and these can work quite well too. We also use a lot of nurse-led clinics. We use these for titration of pulmonary hypertension therapies. So when patients have started on therapies that need regular up titrations, they have weekly consultations booked. Patients are on more complex therapies. We call them on a regular basis to make sure that they're managing well. And especially when they have started on IV therapy, we will call them when they're up titrating or when they're making up their next batch at home, to make sure that they've got the added support. They also always have our telephone numbers to make sure that they have support just in case that there are any emergencies at home. We run clinics for up titration of diuretics for patients with right heart failure, and I run a regular nurse-led clinic for patients for assessment after they've been on therapy for 1 month for a formal review, and especially in lockdown, providing additional psychological support. And we know that patients are finding being in lockdown and being shielded is quite difficult. Our Patients Association have run several surveys during lockdown, and this first survey that they ran in the early stages of the pandemic, in the months between April and June of last year, showed that 96% of patients actually were very satisfied with their consultations over the phone. It will be quite interesting to perhaps run that again now that they've had telephone consultations for a lot longer, to see if they're still quite so satisfied. But I'll show you some more data that they've had from the shielded voices, to show that they are finding it difficult, but certainly at this stage they're happy with their telephone consultations, and some of them are very satisfied. But as clinicians, we're not totally satisfied, because although the patients are quite happy that they're not travelling, we're not getting as much information just by talking to them over the phone. So we, with the help of the Patients Association, sent out some information to try and get the patients to make the most of their remote appointments. Because what we were finding is that some of them were using the remote appointments as not important, or finding them not as important as perhaps the hospital appointments. And so when we were contacting some of them, they were perhaps in a situation where they couldn't talk as much. One of the patients was on their way through a McDonald's drive-through and asked if we could call back 10 minutes later. Other patients weren't prepared, so they didn't have their medication list. Other patients hadn't filled in the questionnaires that we'd asked them to. And so we worked with the Patients Association to come up with a list to be prepared for their consultations, as they would do for their hospital ones. And this actually has worked quite well. We also came up with a list of information that we would ask our clinic patients to prepare before their clinic appointments with us, so that we could get even more information for them. especially because we couldn't perform the investigations that we would normally do if they were face-to-face. So we couldn't get tests such as echocardiograms, cardiopulmonary exercise tests. So we were asking them to perform things like 6-minute walk tests, remote blood tests, and I'm going to talk a little bit more about these. So the 6-minute walk tests would normally be done in hospital with a hall walk. So we looked at different ways of doing this. So one of the ways is to use an app on the smartphone using Strava. Now there are several different apps that you can use, but we found Strava to be one that is fairly easy to use, and it's free to download. For patients that haven't got smartphones, they can measure out an area at home or in their garden, and use that same area each time to do their walks. But Strava has been particularly successful, and this is sort of what it looks like when the patients will send it in. And it's fairly reliable, and we always ask the patients to do their 6-minute walks in the same area where it's flat on a day where the weather is fairly okay, so it's not very blustery, it's not very cold, it's not incredibly hot, just so that this is reproducible at home. So although it won't be the same as the hall walk in the hospital, it will be reproducible and will give us a good idea of how they're managing from appointment to appointment, especially over the year that they've been in lockdown. And then they send it in to us via email, and this is a good indication of how they're managing what their exercise is like. We also like to collect remote blood tests, and we send out a prepaid box to the patients. They go to their local general practitioner, who will fill the bottles that we've sent out. They then get sent back to us securely via a prepaid box, and they get analysed at the Hammersmith Hospital, so we have the results ready for their consultations. We ask them to collect their weight at home, just to make sure that this isn't increasing significantly as a sign of perhaps fluid retention, and if they've got the equipment, to collect their blood pressure, their heart rate, and oxygen saturations. We do like them if they're able to download the app and perhaps check their heart rhythm using something like a FibriCheck. Unfortunately, if they don't then delete this after they've checked it, this is an app that they're sometimes asked to pay for. So we say, check your rhythm and then delete the app. And some of our patients have a live core piece of equipment, which is just a small strip that they can buy. It costs around €100, and that is a small strip that they put their fingers on, and then it talks to their phone and it can record their heart rhythm. They can then send it to us as a PDF, but only the patients who tend to have palpitations or arrhythmias would normally invest in this kind of app, and we certainly wouldn't recommend that patients go out and buy this just to check their heart rhythm for clinics. We also quite like patients if they've got any kind of step counter either on their telephone or on something like a Fitbit, just to be able to tell us what the average walk step distance is, because this gives us a good indication of how much they're doing on a daily basis. Because you'll often find patients will say, oh, yes, I'm doing lots of exercise, and you'll find that their average step count may only be 1,000 steps, especially during the pandemic lockdown. And one of the reasons that we like to collect information such as the 6-minute walk test and the blood tests, which will include BNP, which is a measure of how much the heart is under strain, is because it helps us as clinicians decide on how much the patient is at risk. This is actually a risk of mortality, and I don't know if any of your clinicians would ever share the risk score, but this is something that we very much look at. Now, when we're talking to you, very often, when we're doing an assessment, we'll be assessing for your level of risk. So when we talk at an assessment, we'll be looking for things like signs of heart failure. So we're asking, have you got ankle swelling or abdominal bloating? And so we're able to assess that. So when we talk at a consultation, if you've not got signs of ankle swelling or abdominal bloating, we can say, well, they're absent, so that's good. Are your symptoms getting worse, or are they stable? And if they're not getting any worse, that's good. Have you had any blackouts? No. Well, that's good as well. So that puts you all in low risk. Functional class. Are you able to walk at a normal pace on the flat? Can you keep up with everybody else? Now, unfortunately, most people with pulmonary hypertension do tend to walk a little bit slower. And so say I'm talking to somebody, one of my patients, and they're sort of saying, well, I can't really keep up with everybody else. I slow down a bit, or they slow down for me. So that will probably put them into functional class 3. And this is a lot of people in lockdown at the moment. And say I've got their walk test, and last time they walked 450 meters. This time they're walking 400 meters. And I'm thinking, they're a bit slower. This puts them into intermediate risk. This has put their risk up a little bit higher. So I'm thinking, is their pulmonary hypertension worse? They're telling me that they're walking, their step count, because they have got a smartwatch, is around about 3,000 steps a day. So they're fairly active in the house. So I think, that's okay. I haven't been able to bring them in to do any cardiopulmonary exercise testing, and I haven't been able to do an echo. So I'm thinking, do I need to bring them up? But they've sent me some blood tests. And on their blood tests, their BNP is 38. So actually, I'm really reassured by that. I know that actually their heart is really quite good. And then when I question them a bit more, they say, well, I've not really been going out. The weather's not been good. It's been over the winter. I'm not really motivated to go out. And actually, I'm really worried that I'm going to catch coronavirus. So I've been active in the house, but I've not been out for any long walks. I've not really been pushing myself. And the 6-minute walk test was the longest I've actually walked outside the house. So when I look at this picture, actually, I'm reassured that actually they're probably just a bit deconditioned. And so as a clinician, I'm quite reassured that I don't need to be suddenly rushing to bring them into hospital to do more imaging, to do cardiac catheter or anything like that, or to put them on the exercise bike. But if they'd have sent me in a blood test and their BNP had gone up to sort of 400, I would be much more worried. So being able to collect these extra tests actually is really quite essential, and it gives us a lot better picture. So I think being able to collect those extra tests is really very important. And the other thing that is incredibly important to be able to collect is the quality of life questionnaire. And in the UK, we collect the Emphasis 10 questionnaires, and these were designed by our patient association because they're easy to fill in, and they're really easy to score, and I think they're essential because they give us lots of information, not only about the clinical picture, but also about the psychological picture. Because what we do know, and this is some shielded voices again, that Even just at the beginning of the pandemic, I said this was from a year ago, that already 81% of the patients that were surveyed felt distressed by being confined to their home. I said this was at the beginning of the pandemic. And a third of those felt extreme or much distress. And 91% of those patients felt that their emotional or mental well-being was affected already, and a third of those said it was severe or a lot. So it's really important that not only do we talk about the physical aspects of pulmonary hypertension, but we talk about the psychological ones as well, so that we can actually deliver holistic care. Because there's lots of help and resources out there to cope with stress, anxiety, and isolation during the pandemic. On our patient website, there's a whole page set aside to all the sources that they can actually access. They should not be suffering in silence. And so one of the things that we can do as well is to set some of these achievable goals, meaningful, realistic, and achievable goals, little things that you can actually do at home. Some of them can be like physical goals, so being able to undertake gentle exercise at home. So just because you can't go out doesn't mean that you can't exercise. And some exercise and actually getting out there and getting some sun is essential, because not getting in levels of vitamin D can mean that you can actually get more depressed, and your physical and bone health can deteriorate. It's essential, especially when some patients and their relatives are not able to work, that they're aware of all the available financial benefits that they can claim. And then we can also liaise with employers to make sure that the patients are able to shield at home and are not going out into situations where they are potentially putting themselves at risk of catching coronavirus. And there's also support out there for not only the patients with pulmonary hypertension, but also their family and their carers. And it's really important to know that they're not alone during this time. So the support is out there, and they just need to be signposted to know that it's out there, and they should not be suffering in silence. And there are several things that you can do whilst you're at home to actually help you with the disease. So knowing your disease, knowing what pulmonary hypertension is, as in there's lots of information, especially on patient websites. Know what your medications are, know what they're there for. Keep an eye on your fluid retention. If you're not moving as much, there is a potential for putting on more fluid. And always seek help when you've put on, 1 or 2 kilos, before you've put on 10 and then it becomes an emergency. It's always better to alter your diuretics at home rather than need a hospital admission, especially at times like this. Keep active as much as possible, even if it is in the home. Keep connected with your friends, your loved ones, people at the hospital as well. Stay busy, take up new hobbies, things that you'd not thought of before. Now is the ideal time to, find the inner artist. Start things like knitting, crocheting, read the book that you've always wanted to read, read the book that you've never thought to read, and ask for help. There are lots of people out there that are willing to help, and there are lots of sources of help out there. At that, thank you very much for listening. And I wish you all the very best. Thank you.